to talk.
Good afternoon, everyone. I'll be talking for non-supervised independent surgeries for third-year residents in ophthalmology. So, just to put the current scenario of ophthalmological surgical training in India, see that the open eye on the left, which is the left eye, obviously, is a third-year resident who has done all the mundane activities in like ward duties, eye donation calls. He has done his thesis work, clinical duties. While the covered right eye is a like surgical expertise that he gets during his 3 years of training. So what is expected? So as we see in this current article published by Grover et al., we can see there are like a lot of times they have emphasized upon like what all surgeries that should be performed independently by the end of a residency of an ophthalmic resident. He should be well versed with all kinds of block. He should be able to perform independent surgery, and not only able to perform independent surgery, but at the same time he should be able to tackle all the different kinds of complications of all these lid surgeries, destructive procedures like enucleation, evisceration, sac surgeries, strabismus surgeries. He should be able to perform surgeries under microscopes, and the most common surgery, like the bread and butter of ophthalmology, which is the cataract surgery. And he should also be, if not able to perform independently, he should be well versed with different steps of vitreoretinal procedures like vitrectomies. So this is expected from a third-year resident of ophthalmology. So now just to take idea like how is the training abroad and what should be the proposal for India, and taking the two common models of US and UK. In US, it's the program is of 3 years duration, and the number they have recommended that a postgraduate should do at the end of their training is 86, and most of them they end up doing somewhere around 120 of surgeries. While in UK it's a 7 years program, the number recommended is 350, and they end up doing around above 500 cataract surgeries. And our article published by Dhaliwal et al., they have proposed that at least the residents should do 80 surgeries independently. Independent 80 surgeries, cataract surgery, which would include 40 SICS and 40 phaco. Likewise, numbers for TRAPs, RDs, plastics surgeries, and trauma. And what do postgraduates say? So on the number like which is displayed there, it's not a mobile number. It's the median of different kind of surgeries that is being listed in the table. You see the median for ECC is 17, for SICS is 2, and it's 0 for phacos, and even for a surgery like pterygium, it's 0. So what to talk of other specialty surgeries? And this was the article published in 2008, and a similar article published in 2014. It doesn't also put encouraging figures where the median number for cataract surgeries was 19. So what is essential? So this article by Grover et al., they say that at least the bare minimum of cataract surgery that PG should do independently is 50, and 5 each of glaucoma surgeries, squint surgeries, eyelid surgeries, sac surgeries, and eye retrieval procedures. The point of concern is this recent article published in 2017, which says that the median number of surgeries performed and by a resident at the end of his training is 55 for SICS, 30 chalazion, 18 ECC, and the most common procedure that every ophthalmologist should be aware of, that is phaco, the number was 1. This is a median number of phaco surgery that a resident gets to do at the end of his training. The point of concern was that lowest range, even for surgeries like chalazion and pterygium, was 0. So that is actually a point of concern, and are we like training our residents properly or not? We should look back into it. So what are the possible reasons that these postgraduates are not being given surgeries? So one of the reasons is inadequate infrastructure or lack of motivation on part of trainees, fear of complications, and not keeping up with advances. And then if the surgery was not given to me when I was a resident, so I will not give surgeries to my residents. And why to give? This is the best time for developing reflexes. And where else they will find a more comfortable environment than their from where they are doing their PGs. And then that is the best time when they can cope up with complications, and of course it will save precious time. All of them, they have to do go to do different kinds of fellowships and then adjunct faculties and so on and so forth. So just to conclude, I'll conclude with this picture that like at some point of time the supervision has to go, and then only the person can learn. Thank you.
Yeah, thank you very much, I think.